All right, well, we'll go ahead and get started. We were letting everyone have a few minutes to join the webinar. We want to welcome everyone and thanks for joining the session today. We have a big group and we have a good discussion here that we're talking about the much anticipated changes coming as it relates to E&M coding in January of 2021, which is crazy to think it's just a few weeks away now. And we just want to cover some of the key things from the Coker team's perspective, what we think are most pertinent that you need to know as far as these changes. My name is Mark Reibold. I'm a Senior Vice President here at Coker. And lucky for you, you're not going to have to hear much of me talking today. You are going to hear from a few of our team members here at Coker, and we're gonna dive into this issue deeper here momentarily. I want to introduce our speakers today. What we did was break down this topic into kind of two categories, if you will. First, we're going to talk about the coding changes from a financial perspective and assessing the impact on revenue, specifically physician compensation, which I know is on the top of minds of many of you all. So that's going to be something we're going to dive into. Covering that is going to be two gentlemen on our compensation team, Alex Kirkland and Amit Vaishampayan, and they're going to cover the comp perspective and financial perspective here. And then after that, we're actually going to go over and talk about the impact of these changes from a coding protocol and process standpoint, coding and compliance. And the two individuals presenting on that, we have Jeannie Cagle and Roz Cordini, both in our coding and compliance team. So we think that made a lot of sense as far as covering this broad topic from a few different angles. And again, we're going to dig in deeper here. Just a quick housekeeping item before we jump into the slides. I want to encourage everybody, if you have any questions, there's a little button at the bottom of your screen that is Q&A. And I know we're all pretty familiar with Zoom by now, so some of you have already found the chat box. Feel free to use that for chat, but if you do have a specific question, we're going to just leave that open, that Q&A box open, and allow you all to submit your questions as we're going, and we'll try to address as many as we can as we're going through the slides. We do have a packed agenda today, so we're going to try to get to as many of those as possible. If we don't get to your question, we'll make sure to follow up with you and we'll get you an answer offline. But please feel free to submit any and all questions you may have as we're going through the slides. Also, I want to mention part of the way through the presentation, we're going to have a poll for everybody to participate in, and so that will come up on your screen, but just kind of be ready for that when it does pop up here in a few slides. But with that out of the way, I want to bring up Alex and Amit and talk about the financial perspectives of the 2021 E&M coding changes.
Fantastic. Thank you, Mark. This is Amit, and it is nice to be here with everyone virtually. We are going to kick off this presentation just talking about the financial perspectives. And specifically, we will do a quick overview of the economics that inform those perspectives. We'll talk a little bit about the service line and specialty level impact, and then we'll have some call to action steps for everybody. We have heard a lot of anxiety from folks, clients, and just healthcare leaders in general, and we can certainly empathize. We have a great call to action for you. So with that, let's go ahead and get dived in right away. I think a great place to start is really, how is physician reimbursement under the Part B, under the MPFS really calculated? I think the formula is something that everybody has some degree of familiarity with. Some perhaps work with this every single day, others not so much. So I think this is a great place to start because it will frame up the rest of our discussion here. So at a very high level, essentially there's three steps to this equation. First is really looking at the relative value units. There are different components of the RVUs. There's a work component, which is really the physician resource, the physician time. It's, it's what the provider is actually doing. That added with the practice expense, which is all of the costs, the operating costs that are incurred to provide that professional component of work. And then there's a malpractice RVU component, which is really professional liability expense associated with that work. So the aggregate of those components gets you to a total RVU. And then that total RVU is, there is a geographic price cost index, a GPC, that is applied to that total RVU that gets you to the geographically adjusted RVUs. So for example, the GPC in a Chicago, for example, metro area is going to be much higher than a GPC for a rural Illinois. And so once you get to that geographically adjusted RVU, when you multiply, you're going to multiply that by the conversion factor to arrive at your Medicare allowable. And so I think it's noteworthy to point out here that this formula itself, the mechanics aren't necessarily changing, but there are some variables that have been fixed, so to speak, for over a decade now. And those fixed variables, which are highlighted in these orange boxes, are actually changing as a result of the final rule. And so those have a profound impact. And we are going to be talking a little bit more about that impact. Let's go ahead and step on to the next slide. So I think one of the things that is key to mention here is this Budget Neutrality Act. And so what the Budget Neutrality Act is, it's basically emphasizing that the pool of dollars are not necessarily changing with these different kinds of, with these final rule changes. There is going to be different, there are going to be increasing and decreasing RVUs across different specialties, but the net impact is really, it's a net increase in the RVUs. So essentially, if you're looking at the same pool of dollars in terms of healthcare expenditures, and you're looking at a net increase in RVU amount, what that means, or what that translates into, is essentially a decrease in the conversion factor. And this decrease is actually the biggest we've seen, again, over a decade, and it is going to be so very impactful. We will definitely get into, and my colleague Alex will get into in a little bit here, which specialties are seeing the increases and the decreases in RVU amounts and the corresponding changes from a financial ramifications perspective. But that's all good stuff that we are certainly going to get to. All right, this slide here, I mean, essentially what we're showing is that on the orange line below, you are seeing the CMS conversion factor. And as I had mentioned on the previous pages, we're going to be seeing a 10.2% year-over-year cut that is driven by the economics and that is driven by the final rule. What's really interesting is the blue line represents essentially compensation for RVU to physicians. And this has been trending up, as many of you know, over the last few years, and will continue to trend up. And so it has already, even before this year-over-year cut in the conversion factor, it was starting to become unhitched. And now, we are seeing a much greater degree of unhitch in terms of comparing the compensation with the reimbursement. And so what is really noteworthy here is that the surveys that so many of us rely on, those are all based on a paradigm that was largely unchanged for so many years. And so reliance on the same data in 2021 and going forward is just going to be very challenging, because it may actually result in a material misalignment between the relationship of compensation, productivity, and collection. So I think this is an area where we've done a lot of work, and we have certainly heard a lot of folks expressing angst We've got a couple examples for you, but before we get into those examples, and before I transition it to my colleague Alec, I know that we've got a quick polling question for everybody in attendance here about the preparedness of the organization.
All right, well, hopefully everyone had an opportunity to vote, and we're going to advance over to the next slide. And now let's talk about these changes, what they mean to different specialties. They mean different things. They're said differently. There's a different amount of financial impact associated with different specialties. You'll see on the right-hand side, we took a table straight from the final rule. This is table 106, and just selected some key specialties, where based on 2019 utilization data, Medicare utilization data, they factored out, juiced that up to look at it in terms of what the 2020 economic variables would be. That's what that allowed charges are going to be. This is essentially reimbursement across the country from Medicare for these respective specialties, and then applied these prospective changes that are going to take place in 2021, either the changing RVU numbers or the decreased conversion factor will have an impact across specialties. And it'll affect them differently because the specialties have a different makeup of services involved. The predominant changes on the RVU values are going to be associated with E&M services or services that are analogous to E&Ms. And so you'll see that for family practice, internal medicine, and nephrology, who generates a lot of their RVUs from dialysis visits that are analogous to those E&Ms, those are specialties that are expected to receive a windfall. They're going to receive increased reimbursement in 2021 per CMS's estimates. But other specialties such as anesthesia, general surgery, ophthalmology, some of the surgical specialties that generate more of their RVUs from surgical procedures are anticipated to see a reduction in reimbursement. I do want to caution you that this is a broad analysis that CMS put together, where they stated that further insight is needed to really assess your economic situation. This is based on national utilization data, your service mix and payer mix between Medicare and non-Medicare payers could differ substantially. And so it will be very prudent to conduct your own analysis, but view this as a directional insight into where some of the reimbursement changes are occurring. And if we go on to the next slide, we'll just break this down a little bit further. We kind of call this our tale of two specialties, where we'll demonstrate some examples between family medicine and general surgery. So at the top, you'll see work RVUs from 2020 to 2021 are demonstrated. This is based on the same volume of services. But by virtue of the RVU values for E&M services going up, you see a higher anticipated increase related to RVUs for family medicine than you do for general surgery. Now, it's likely that general surgery will still have an increase in RVUs, but not to the extent that family medicine does by virtue of having a different services mix. The compensation per work RVU. This is an amount where if you have a fixed amount or leave this unchanged, you can see how this has a resulting impact in compensation. So at $51.70 based on 2020 RVUs, compensation for family medicine is going to be about $258,000. But that increases to $279,000 in 2021 just by virtue of the RVU values going up. Now remember, the utilization number stays the same, but the RVU values are increased. So, but the collections are also increased. And so for family medicine, where providers are on a per work RVU compensation plan, and they'll receive more payment for the same work. So there's this fixed compensation dynamic. It's going to create this service line windfall. But in general surgery, it's a different story. You can see a mild uptick in work RVUs. Again, based on same utilization data, just the value of RVUs are going up, some E&M services that they conduct. If that compensation per work RVU number remains fixed, then their compensation is going to go up, yet the cut in reimbursement for that conversion factor is going to result in fewer collections for the service line. So that fixed compensation amount, it's going to result in a service line loss. I believe there's a question that we had submitted that said, do you just need to multiply the conversion factor by the work RVUs to kind of see that difference? And they're really two separate variables in place. How are you setting those compensation per work RVU amounts and analyzing that in tandem with how your collections are moving? Let's go to the next slide. And so what should you do about it? At the bottom, you can see one of my favorite quotes from business by the famous management consultant, and I use the term famous loosely when it comes to management consultants. But I love this quote that says, without an action plan, the executive becomes a prisoner of events. So you need to be planning proactively. How can you address these anticipated changes? And our three-step call to action is, number one, don't panic. You can freeze, if you have the ability to freeze your existing RVU values and payment rates, that will give you time to analyze the situation, wherein you can run CPT level scenario projections to assess what revenue changes you're going to be able to anticipate in 2021, and then research what contractual commitments you have within your physician compensation plans. What leeway do you have to adjust physician compensation variables so that you're not hit with a double impact of decreased reimbursement and increased physician compensation payments? And then finally, as that analysis comes together, implement a plan, review the results, weigh the alternatives, and determine the appropriate course of action. On our next slide, we give you some insights as far as how you can what you can do today. How do you start this? Well, on our website, we have a calculator where you can go in and punch in your volume of CPT codes, both for established and new patient visits. And you can put in a variable compensation rate per work RVU amount to assess what that directional impact looks like. This is the presentation that will be available for everyone following today's webinar. There's a live link in it to our impact calculator, but it's also easily found on our website. You can further that analysis by expanding your analysis to include CPT level reports, starting to analyze exactly what that reimbursement and compensation impact will be. And then we are working with organizations across the country right now to do that exact analysis and understand what contractual commitments different organizations have so that we can help them craft a go-forward action plan. How should they respond to this? And we'd be happy to support anyone that has interest in that regard. So at this time, I'm going to turn it over to our coding experts to talk through the E&M changes that are going to take place in 2021.
Well, thank you, Alex. This is Roz Cordini with Coker Group. And we're going to talk next about how to prepare and use that same call to action to address the upcoming 2021 E&M changes. So first of all, it's important to note that this has been a multi-year project between the American Medical Association and CMS. And it was called their Patients Over Paperwork program with the goal of simplifying physician documentation. What CMS has said, and it'll be interesting to see over time if this turns to be true, but they said that they anticipate this will save about 180 hours per provider over the course of a year. That has yet to be seen. One important thing to remember about these E&M changes is that they only apply to your office and outpatient physician visit E&M codes. So we're talking specifically about 99201 to 99215. And what that means is that if you provide services in other locations, for example, a SNF, hospital, ER, observation unit, etc., the current 95-97 guidelines are going to apply in those locations. So unfortunately, we'll have to still be a little bit schizophrenic for a while and remember our current guidelines in addition to applying the new ones in the office outpatient setting. And the clock is a ticking. We got the final rule earlier this month. And so all of the changes that we're going to be talking about today are going to go into effect on January 1st, 2021. Next slide, please. So what are some of the challenges we have had with our current guidelines? You could probably create your own list and you may be able to add some to our list. First of all, they're super old, 25 years old, more than 25 years old, and they're certainly antiquated. And under the current guidelines, this whole process of counting bullets in order to try and quantify how complex your patient care is doesn't always work. And that's especially true with the advent of electronic health records, where the review of systems and exam are not only tempting to over-document, but sometimes, and in many instances, our templates have been set up in a way that automatically documents certain normal findings, giving the impression that they've been reviewed when maybe they haven't been, and leading to over-documentation. The required documentation that you need to meet a level today can be redundant, it can be irrelevant. You know, if you're treating a 95-year-old patient, how important is it to go into such great depths regarding their family history? Or maybe you're seeing a 10-year chronic sinus patient. Do you really need to do a 10-point review of systems and look at their hair growth, et cetera? Probably not. And importantly, one of the biggest frustrations, not only for providers, but coders alike, are that terms used in the current guidelines are not well defined and they're subjective. Next slide, please. So some of the key changes we're going to see starting January 1st. Number one, 99201 is going away permanently. They found that there were very similar requirements to 99202, not billed by physicians and APPs primarily, and so they have eliminated it. The history and exam, which were so important in our current 95-97 guidelines, are not going to count anymore in leveling your E&M visit. So on when the interim rule was out, say, well, that's great, we don't have to do histories and those review of systems anymore. And of course, that's not true. You still have to do them, but it is completely up to the provider to determine what is medically appropriate for that visit that they're treating the patient for. Now you're going to find there's only two ways to level your code. It's either going to be based upon time or medical decision-making. We do have some new codes, prolonged services, that are going to be in 15-minute, 15-minute increments as opposed to the current 30-minute increments, which is good news. And really important are that all the documentation guidelines have already been printed in the 2021 CPT manual. And they've hard-coded those definitions and other areas where we had some ambiguities in how to interpret things. And of course, we have the CMS final rule. So I'm going to turn it over now to Jeannie Cagle to talk about one of the new codes we're getting and to delve a little more deeply into the time and medical decision-making components. So next slide, and Jeannie.
Great. Thank you, Roz. One of the things you may have heard that has gotten a lot of press is a new add-on code, G2211, that CMS introduced in the final rule a couple of weeks ago. And everyone's pretty excited. CMS is saying, hey, 90% of you can use this. One thing I want you to keep in mind is anytime we have new guidelines come out, they give us directives. But then those of us who wear an auditing hat or think about defending or teaching physicians, we have all kinds of questions come up. This particular add-on code is meant to be added on, primarily used by primary care or specialists who see patients over a long period of time. It has a payment of about $15, and it's basically to say there is a lot that goes on with this patient. It's in addition to the E&M. Interestingly, they've not told us how to document it appropriately. What they've told us is what doesn't count. And so they've said it's not for quick and easy visits. It's not for something simple. You can see at the bottom of that slide, things like a virus, allergic rhinitis, those sorts of things do not apply. Here's my years of experience, what I want to say about this. I am cautiously optimistic that this code could be beneficial. It's just, at this point, it's still vague. Another question that has come in that I want to clarify based on some of the overall changes, they are only for office codes. Like we said earlier, office consult codes are not affected. So those of you who have specialty practices where you still have insurances that will accept a consult code, you're going to have to decide whether or not the extra work, the history and exam that's still going to be required for those office consults are worth your time and energy, because they do not fall under these new guidelines. Okay, next slide. One thing that Alex and Amit have already alluded to is the fact that there has been an adjustment in the RVUs. This grid just lets you see the percentage of increase for each of these levels of codes. Of course, some of those have been offset by the conversion, but still, this is very helpful for those practices where their primary billing is for E&M codes. So now that we know we have, next slide, 2 options, either time or medical decision-making are the way you will determine a level of E&M starting in January. So let's just drill this down a little bit further and talk about each of these. First of all, option 1, let's talk about the time documentation. So what this is the total time on the date of the encounter. Here's what's different. Currently, it's face-to-face time with the physician or the provider that counts toward time. Under the new guidelines, it can be face-to-face, or there has to be a face-to-face component, but it is also other time spent by that provider on the same date of service. So a lot of times you spend times as a physician getting ready before the visit, conferring with other providers, doing a lot of different things that go into the care of that patient. All of that will count toward the time that you can use to bill for that E&M level. It's very important that you know it is not staff time. It's not your nurse or the front office. It's only time spent by the physician. On the next slide, there's a list that the AMA has given us to give us an idea of the sorts of things that physicians do outside of face-to-face conversation with the patient that may count toward this time. And there are obvious things on this list, like reviewing tests or getting information from other sources or conversing with, let's say you see a patient and then you want to talk to a specialist in their behalf. As long as it's on the same date of service and you have documented the time in your note, then it can be the supporting factor for the E&M code. What do we need to document? That is a great question. There's some things to keep in mind if you decide you're going to use time. On the next slide, you can see that you will have to weigh out whether or not you lose your efficiencies. In my opinion, in interacting with physicians, most of the time, if you're able to see a patient in less time than what is usually described by a particular level of code, then see the patient and move on to the next one and bill based on medical decision making. Time is most likely going to be helpful when you have someone who's come in with old records, you're doing an extensive workup on the patient, and you review that information before you see the patient and give them information, or perhaps you've gotten some kind of high-risk new diagnosis. In primary care, it can be non-compliant patients or patients with social issues. There are a lot of times when a visit flips to being very time-consuming. Currently, there is no specific guideline that says, here's exactly how you document time to support your code. It doesn't say start and stop. Times must be there. It doesn't say 5-minute increments. But let me tell you what I know for sure. First of all, you no longer have to say greater than 50% was spent in counseling and coordination of care. And whatever you document has to support the medical necessity for the time spent. You cannot see a perfectly healthy patient for otitis media and write a prescription and then say, I spent 60 minutes, because medical necessity, based on what I just told you, is not supported. But put enough in a concise statement that says, here's how I spent the time and why it was time consuming. Here's an idea. If you think time might work in your practice, then just take a day and say, I'm going to see if I can keep track of this and be able to give an accounting of my time and see if perhaps it's beneficial. And if it is, then go for it. On the next slide, you'll see that these are now listed in what's called a time range. So there's a beginning to end time in minutes for each of the levels of E&M codes. Used to, we had a typical time. Now there's a range. All of the codes in orange on your screen were tweaked just a bit from the typical time that we're currently using in 2020. So you can see that they've gone up just a bit for level 3 and level 4 for follow-up patients, but they're 5 minutes difference. But here you can see what time are for each of these. One thing to keep in mind, this is interesting, once you max out the time, remember we said there are new prolonged services codes. AMA came out with 99417, put it in the CPT book, but when CMS came out with the final rule a couple of weeks ago, they came up with their own G2212 code. The reason is they do not agree on how to apply this code. The AMA says, let's take 99215, for example. You have to max out the number of minutes to the very top level. So as soon as you hit the 40 to 54 time range, the AMA says you add 15 minutes. So as soon as you hit 55 minutes, you can bill 99417. CMS says, not so fast. We want you to take the high end of the range, 54 minutes, add 15 minutes. And when you get to 69 minutes, then you can bill the prolonged service code. What your other insurances will do, what they adapt as far as their own way to bill for this prolonged service, you'll have to check on those individually. My guess is most folks are going to really like that CMS interpretation, because truthfully, it makes more sense that it not just be 1 minute over the limit. So if you decide you're not going to use time, that perhaps you see an awful lot of patients in a day and you want to do medical decision making, let's just drill down and see how would you decide to bill based on medical decision making. You can see there are 4 levels of codes. This is not new. This is what we're using now. We're using level 2, 3, 4, or 5. Here's what's interesting. New or established patient, medical decision-making is identical. The work and the documentation that the physician has to document is the same, whether it's a level 3 new or a level 3 established, they document the same thing. The only differentiation is whether or not the patient's been seen in the last 3 years by you or one of your specialty peers. Now, the assumption would be you would do a little more work for a new patient. Remember that history and exam that's going to be clinically appropriate, and you're going to decide what you have to do. The assumption is you're going to do a little more work because they're new and you're completely starting from scratch. And yes, the reimbursement for a new code is higher, but your documentation is actually going to be identical. So a lot of docs, they keep asking, are you sure? I'm sure. So what is medical decision making? Well, it includes 3 categories, and I'm going to show you a grid in just a minute that has these lined up, but there are 3 columns for you to consider when you assign the level of code. The first is the number and complexity of problems that are addressed. That term that are addressed is really important. Simply listing them does not count. You have to address them during the visit. The second column is data to be reviewed and analyzed. And then the third is risk. What are the risks this patient faces based on either a decision to do more diagnostic tests or on the treatment plan that you have decided in order to treat the patient? If you look on this next slide, you'll see we're going to show you how you calculate medical decision making. This is the grid from the AMA. Now, I know if you're not looking on a 60-inch screen, you can't read all those words. But if you want to go on the AMA website, you can actually print this off. And I'm going to break it down for you briefly and let you see what each of the rows are. But this is everything you need to know to assign a code, new or established, under medical decision making. So you can see they've made it a lot more concise. So let's break it down. The first row is level 2. Remember, new or established, it's all the same. First column, the number and complexity of problems. Well, one self-limited problem is enough to support a level 2 visit. In the center, you see the amount and complexity of data, and it's either no data or minimal data. And then to the far right, we have minimal risk. This is really a very straightforward visit, clearly. And you only have to meet the criteria for 2 out of 3 of the categories. I'll go ahead and tell you, and if you know your left-hand column, which is problems that they present with, which everybody's coming in with a problem, right? And to the far right, the risk, it certainly is going to be in most every visit that you have. Data certainly will apply in some of your practices, but you'll find places where it really doesn't apply as well. So I'll show you that as we go along. The bottom line is a level 2 problem is very easy to meet the level. Remember me saying earlier, there are some definitions now that we've not had in the past. They have defined for us, what is a self-limited or minor problem? Well, it's a problem with a prescribed course that's transient in nature, not likely to alter permanent health status. So, you know what my definition of a level 2 presenting problem is? Well, if you hadn't come, it probably would have gone away on its own. We're talking about things that are very cursory and not a big deal. Let's look at level 3. Same headers, but a level 3 problem, you either have 2 of those self-limited or minor problems that we just talked about, or one stable chronic illness, or one acute uncomplicated illness or injury. All of these have definitions under the new guidelines. If you go to the far right, whatever you decided to do to treat this particular problem or any test you ordered, it still had a very low risk for the patient. Now you're able to see in the middle what this data category has included, which is interesting and a little different than what's been in there in the past. You have to meet one of these categories, and you'll notice that ordering test gives you credit and each test stands alone. So that's something a little different than what we've had in the past. But you notice each unique test that has a separate CPT code that you order, you get credit for those under this data category. The second category, assessment requiring an independent historian. This is any time the patient is unreliable or unable to give a complete history. So if you have a caregiver, a family member, someone there who can give you more information about that patient. And by the way, it's been clarified by the AMA, this does not include an interpreter. Then that included in your documentation gives you credit for more data to get to limited data to support a level 3. Let's look at level 4. This is going to sound a little familiar. A lot of this is a lot like the table of risk that we're currently using. A chronic illness with an exacerbation, progression, or side effect of treatment, 2 or more stable illnesses, 1 undiagnosed new problem with an uncertain prognosis, an acute illness with systemic symptoms, or acute complicated injury. These all sound familiar. They've been tweaked just a bit. It's no longer mild exacerbation of those chronic illnesses. Now it just says any kind of exacerbation. But all of these have definitions, and I think you're going to find that very beneficial. To the far right, we've got good old prescription drug management that makes us all fuss and fight and carry on when we decide what does it mean. We've got decisions for major and minor surgery. One thing added here is diagnosis or treatment significantly limited by social determinants of health. These are folks who have social considerations that keep them from getting good care. In the center, you'll see more listed options for data. One that's been added here, discussion of management or test interpretation and interpretation of test independently. Let's go look at level 5, famous level 5. Everybody's always wondering what counts for level 5. We've got a chronic illness with a severe exacerbation, acute or chronic illness that may pose a threat to life or bodily function. Over to the far right, they've defined better drugs that need toxicity. Notice in here decision regarding hospitalization. You see a patient in the office, you work them up and you say, you know what, I think you just need to go on over to the hospital. Then that would increase this patient's risk. And then as far as data, it's the same as the moderate level 4. You just have to get more categories if you're going to build level and it be part of that. So after I've kind of thrown all of this at you, I'm sure for a lot of you as providers, some of this sounds familiar. What I want to do is just in summary, there's just a few things I want you to keep in mind. Documentation still really matters. You have got to tell from the very beginning. You know, when I'm educating physicians, I'll often say, hey, when you meet a brand new patient, how long does it take you to discern how long this visit's going to be? And I will tell you, most docs tell me something between 15 and 30 seconds, because they can tell once the patient starts talking and they ask some important questions, the physicians do, they get a sense of how complicated it's going to be. If you document what the patient's told you, and it doesn't have to be an epistle, just make it concise. You start to tell the story, and that supports medical decision making. All the detail that you can include. This is a place, for the first time in my 20 plus years of educating physicians, this is really good news for your physicians. It really is. But they're going to have to work smarter and not harder. All that time fluffing up their note with the review of systems and histories or exam elements that did not matter clinically, it needs to be put toward a concise and clear assessment and plan, making sure the complexity of what's going on with the patient and the data that you have done, I would say, is really the most important way to spend your time. One final thought: if you use a code calculator in your electronic medical record, it will no longer be accurate, because counting history and exam will not be part of the equation any longer. So that's something you have got to consider. We have found education in these last few months, and hey, it's not too late if you're thinking, uh-oh, we are way behind. Educate everybody in January. This is the new normal. So do it in January, do it in February. Figure out the best way to get an audience with your physician so they can hear the most important elements of this. We have some clients who have done a 3-hour presentation. My experience, you're not going to get a physician to do it for that long. Be concise, give them great information, show them how to do it in their EMR. I think you're going to find a real benefit with these new guidelines. Okay, so just remember, you can find a lot of great information on the websites, all these websites that I've listed. And Mark, I am going to just turn it back over to you.
Yeah, thanks, Jeannie. That's great. I want us to use a couple minutes here, and we want to be respectful of everybody's time and keep it to about an hour here. But we got a few minutes left, and I'd love to address some of the, or have our team address some of the questions that have come up there. Jeannie, I'm imagining a number of these are probably going to be stuff that if you weren't able to cover in your slides, that
yes,
you may want to address some of them.
Okay, so do you want me to just do the ones from the list that apply to me?
That would be great. Thank you.
Okay, great. If you bill for a test, counting it as an independent interpretation, but since it was billed separately, listen, let me just go ahead and say, some of the things are confusing, and all of your coders and billers don't think they're crazy. The AMA came out with some guidelines, then they did a symposium and gave examples that contradicted the guidelines. And so some of these nuances we are still trying to kind of figure out and tweak. I promise you, as it goes on, you're going to get more information from your MAC, from CMS, from your commercial insurances. So a lot of this has been confusing. When you order a test, yes, you can count it toward the category of data. Where it gets tricky is the AMA has said, but if you bill for that test, then you're not able to do that. So the reason we're all confused is because that language has been confusing. Do I think it's going to be easier to get levels in 4 and 5s from now on and change those percentages? Frankly, yes. I think the fact that now you only need 2 stable chronic conditions to hit a level 4, I think now the fact that data has more weight when you're ordering tests will help get up to that higher level as well. My guess is CMS in particular, and everyone else too, is going to see a shifting toward levels 3s and actually more 4s, because getting there is going to be easier. So back to the compensation question, if you've noticed that shift in your physicians, it may not be they're trying to game the system as much as they're just able to get there with less documentation and less complexity than it had to have before. Can you use the G2211 code at every visit? You know, remember at the beginning when I talked about that add-on code, I said I'm cautiously optimistic, because if you have reflected the complexity of that patient in the level of your E&M code, it's not yet been made clear, then what does this add-on code signify? What is it that it's reflecting that was not reflected in that 99214 that you billed? And so a patient who comes in for a diabetes, follow up every 3 months, can you always add that G2211? You can, but remember, this is only for Medicare patients. It's not for your other insurances, and CMS has not yet clarified what has to be in that note. Let's see. So a patient's coming in for an ER follow-up. You charge for reviewing the ER notes ahead of time, like 2 days before. Then you review them again on the day of the appointment. Can you still bill that time on the day of the, even if you billed it before? Great question. No, you cannot. Cannot bill it twice. And so anything that has been billed at some other time or in some other category, remember the rule of double dipping. You just cannot count things twice. We order a lab or a test and don't bill for the test. Do we get credit for ordering at the first visit? When they come back, do we get credit for review? No, that's a good question too. The AMA has said that it is assumed that the reporting of the results of the test are inherent in the ordering of the test. And so once you give credit for the ordering, then giving the results later is already been counted. If we order the lab, they don't come back for 2 or 3 days. We go back, write a note. If we interpreted, I think that's a nuance of the same question. And here's the thing, look at it this way, one lab code build, to be able to take that one lab up in a lot of different pieces to increase the level of your code really isn't sensible. When you order a test, you get credit for the work that goes with it, but it's not going to be dissected and counted more than one time. Are you expected all commercial insurers will adopt these official E&M guidelines? Actually, if they use the CPT codes, the AMA has already said, so yes, all commercial insurances, this applies to them as well, because it's in the CPT book, which is what commercial insurances use. They use those E&M codes. Will the shift to 4s and 5s cause red flags for future audit? Perhaps. All of this is a lot of that, like I said earlier, those of us in audit world, these are things whirling around in our heads already, because we know there's going to be a shift. Interestingly, when these first came out, they said, hey, you don't have to audit as often. And I'm thinking, as soon as they start seeing shifts, they're going to audit like crazy anyway. But anytime there's changes in behavior overall, then there is a deeper look. Do they apply to office consultations also? No, these changes do not apply to office consultations. So the guidelines in the AMA CPT book that shows like a 99243 still requires a detailed history, a detailed exam. And low-level medical decision-making, those rules have not changed. That's why I was saying you'll have to consider whether the extra work you're having to put into an office consult versus using just a new patient code. If you gain some efficiencies over the time you save, then you may decide to just do new patient codes instead of office consults. Under these 2021 rules for time for new patients, if multiple providers are engaged, is it correct you cannot combine the time? So that's a great question. If you have, let's say they see a nurse practitioner and they see a physician on the same date of service in your practice, you can say you can do 15 minutes with the nurse practitioner and you can do 15 minutes with a physician, being a 30-minute visit. But if they both go in together to see the patient, then you wouldn't double both their time if it was simultaneous, if you follow me there. One other thing to keep in mind, remember, this is in the office. So incident 2 guidelines would not necessarily, they don't apply. We fall into a different category there. I'd be really careful about how you bill that shared visit. Let's see.
Jeannie,
Okay.
I'll chime in. Thanks so much for answering those, Jeannie.
Sure.
I know there's probably other questions. One of the questions, additional questions that had come in was, can participants follow up with any of the speakers directly via their contact info? And the answer to that is absolutely. Feel free to follow up directly with Jeannie or Alex or Mitt or Roz. And if you can't find their contact information, reach out to me. You can find me on our website, cocagroup.com. You can find all of us there, but if we can point you in the right direction, I'd be happy to do that. I do want to be respectful of everybody's time. Again, thank you so much for participating today. These slides will be sent out to all participants via the registration email address after the webinar today. If for some reason you don't get a copy, please feel free to reach out to us and we'll make sure you do actually get a copy of these slides and have access to any speaker you want to follow up with. Again, thank you so much, and we look forward to you all participating in future webinars with us. Thanks. Have a good one.